Hello, everybody. My name is Ava Lutz, and for this presentation topic, I chose to focus on pancreatic cancer and the associated genetic mechanisms that come along with that. This specific topic is pretty near and dear to my heart. Both my grandfathers were actually diagnosed and unfortunately passed away from pancreatic stage 4 cancer. So this is like a really interesting topic for me, and I love, learning more about warning signs and detection and all that kind of stuff. So let's get into it. Okay, so before we get into the definition of pancreatic cancer, the definition of the pancreas, it's an organ located behind the stomach, and it aids with digestion and blood sugar regulation. So you can see that kind of here on the screen. This part is the pancreas. And then you have the head, the body, and the tail of the pancreas as well. But as for pancreatic cancer, that is the definition for that is a malignant tumor that forms in the tissues of the pancreas. So this occurs when cells grow in an uncontrollable manner and they metastasize to other parts of the body. So these malignant cells, they're rapidly spreading. And there's also diagnosis is typically later due to these early signs and symptoms just kind of being absent and not appearing until the disease is really advanced and dangerous. Okay, as for classification, it is classified based on the location within the pancreas, the histology, and then the stage of the tumor or cancer. So as for location, the head of the pancreas, which is in this region, it's the most common place for tumor. It can cause bile duct obstruction as well as jaundice. And as we know, jaundice is the yellowing of the eyes or the skin. And then there's the body of the pancreas next, and then the tail of the pancreas as well. And the tail is often associated with late detection due to lack of early symptoms. Okay, so, and then for our histology part, the exocrine cells, these tumors, it's the most common, and these tumors are called PDACs. I'm unsure if that's correct, but that's what I've been calling them. Pancreatic ductal adenocarcinoma. So these are those tumors. And then we have our endocrine tumors as well, which I call them PNETs. They are the pancreatic neuroendocrine tumors. So the PDACs, they're more common, as I said before. And then the endocrine tumors, the PNETs, they're more slow growing in comparison to the exocrine tumors. And then for the stage, if it's kind of localized, it'll just be confined to the pancreas. If it's a little bit more advanced, this cancer will invade nearby tissues or other systems. If it's metastatic, it can spread to the liver, lungs, lymph nodes, etc. Really anything that it can get its hands on. All right, moving on to the pathophysiology of pancreatic cancer. This cancer begins with abnormal cell growth, which can be attributed to mutations in DNA that control the cell division. So this tumor growth, it can obstruct different pancreatic ducts. This can lead to impaired digestion or jaundice. These tumors invade the surrounding tissues, blood vessels, structures, healthy cells. Like I said before, anything they can get their hands on. But yeah, this can cause abnormal cell growth, abnormal apoptosis, which is typically the healthy and regulated way of cell death, and as well as angiogenesis. Okay, moving on to the genetic mechanisms. So starting off with the oncogenes, which are the mutated forms of genes. The CRAS, I'm unsure if I'm saying that correctly, CRAS mutation. This causes cells to grow and divide abnormally. It's found in over 90% of PDACs, which again, that is the exocrine tumors. So it's super common and it causes cell growth and division. Moving on, so we have the tumor suppressor genes, the TP53, the CDKN2A, SMAD4. These mutations prevent the DNA from repairing and prevent regulated apoptosis as well. So this is really just a loss of cell cycle control, and it allows for unchecked growth and tumor progression as well, which obviously is not good. Moving on, we have our hereditary mutations or syndromes. So this is the BRCA2 and the PALB2, which increases hereditary risk. And this can be linked to DNA repair defects as well. As for causes and risk factors, lifestyle, you have smoking, obesity, heavy alcohol use, diet, maybe your sedentary lifestyle. As for medical conditions, you have the chronic pancreatitis, diabetes. Age and sex are also a factor. This is most common in adults over 60 years of age, and slightly more common in men as well. Then you have your genetic factors, so that's your family history, as well as your inherited genetic mutations. Okay, so further on to signs and symptoms. As I've said many times, these early stages, they're often asymptomatic, which just means that signs and symptoms aren't present. They are absent, so it's harder to detect. But these signs and symptoms consist of jaundice, abdominal or back pain, loss of appetite and unexplained weight loss, fatigue and nausea, dark urine and pale stools, could just be change in bowel movement or excretion, and can also lead to new onset diabetes as well. Okay, moving on to treatments. So the first one I'm going to talk about is the surgical resection, the Whipple surgery. This is called the pancreatic duodenectomy. I'm not sure if that's pronounced right either. That's kind of a mouthful. But my one grandfather actually was eligible for this surgery. And it was crazy. They told my mom this staggering statistic that, even if he got the surgery and it was successful, there was still an 88% chance that his cancer was going to come back. So yeah, that's the Whipple procedure. Then moving on to the chemotherapy, which is more common, radiation therapy, which is often kind of done in combination with chemo. Then we also have the palliative care, which is really just pain and symptom management for patients with advanced stages of this cancer, which is pretty typical considering the signs and symptoms are absent. But yeah, it's just really emotional and physical support. Okay, as for emerging and genetic-based treatments, so we have the targeted therapy. So these are the PARP inhibitors for BRCA mutated tumors. So the BRCA, again, those are the hereditary tumors. We have immunotherapy, which is checkpoint inhibitors for patients. These patients, they have to have their pancreatic cancer cells tested. They must come back positive for these specific gene changes. And then we have, gene therapy, experimental strategies to correct or block mutations. We have genetic testing, as well as clinical trials. Okay, here are my references. And then first question, why does pancreatic cancer often go undetected until more advanced stages? So as I've said before, early symptoms are very vague or absent. There's not really any effective screening tests available, like there is, mammograms for breast cancer or colonoscopies for colon cancer. So by the time that these symptoms appear, the cancer has often spread to nearby organs and caused a lot of damage. Second question is, how do genetic mutations such as KRAS and TP53 influence cancer progression? So the KRAS mutation is in over 90% of pancreatic cancers, and this is the uncontrolled cell growth. And then the TP53 mutation disables the gene that preventing damaged cells from repairing DNA or undergoing apoptosis. So together, these mutations allow these cells to multiply abnormally and kind of avoid death. So this just really accelerates the tumor formation process and spread of the cancer. So these make the tumors a little bit more aggressive and resistant to therapies. Okay, and lastly, what benefits might genetic testing provide for individuals with a family history? So this could, the benefits could be just early identification of, any risk for inherited mutations, just prevention and monitoring. And if someone is diagnosed, they might be able to have a more personalized treatment just for targeted therapies. So genetic testing, it really supports our early detection and better outcomes within families that are at risk for hereditary cancer. Thank you so much.